Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, everyone, welcome back to another episode. Today I'm with Dr. Rick Akin. He's an oral and maxillofacial surgeon practicing in Baton Rouge. Rick, thank you for joining us on the podcast.
Oh, it's great to be here. Thanks so much for the invite for this super exciting subject. I was thinking about if I've ever seen this subject at or a lecture on this at Amos, and I just don't think it's going to get you on a podium anywhere.
Yes. So we wanted to talk a little bit about some of the nuances of tori removal. Yeah, definitely not the most glamorous topic, but something I think we're all doing probably with some regularity. So we'll get into that in just a minute. But could you just give us a brief history of your training and your current practice setup?
Sure. I went to LSU Dental School and then finished the dual degree program at LSU in 2004. I guess I've been on about 20 years. I got to practice 1 year in New Orleans with my dad, and he really showed me a few things, some tips with tori removal. I guess once you've made, at that point he had been out for 20 years or so, 25 years. And, he had made I guess a lot of the errors that you could make with this. So he had showed me a few tips. So we practiced for a year together, and then I came up here after Katrina, and I've been here ever since in a solo practice. There were two oral surgeons in my building when I bought the practice, and both were pretty small practices. I think they shared an employee, and then each had an assistant. So it was a different kind of thing. They practiced really, really lean, and then. So now I have the building, and again, I practice solo. And so I think most of what I do is basically dental alveolar surgery and, implants and bone grafting and things like that. I think that when we talked initially about doing this, I had just gotten a number of, that everything seems like maybe it's recency bias, just because you see a couple of them, they stand out. But it seems like I've gotten more recently. A couple of them have been fairly medically compromised patients, older, that it's gotten to the point where we need to do something. And that becomes a little tricky too, because a lot of times these things have been festered. The tori had been festering for a long time. So anyway, so that's kind of my practice, and I'm a referral-based practice largely.
Very nice. Well, good. Maybe we could just start out with some of the basics. Like, what are tori and why do they occur? Maybe that's too basic for our listeners, but how would you answer that?
I think it's good to start there, because I did try to see if there's anything more recent, anything that maybe I missed in the literature, and there isn't. There just isn't a ton of stuff on, and I really, I think, yet to elucidate the genetic, a primary genetic determinant for tori or exostoses. I think that many of us see these similar characteristics in patients, which is typically, really thick tissues, maybe a history of bruxism, a fair amount of wear, maybe mandibular shape. In fact, I looked up to see if there was any influence, or if anyone had detected anything to do with where the masseter attaches to the mandible, because a lot of times, of course, we see them start in the premolar region in younger patients, and maybe because of the flexural characteristics of the mandible right in the mid body. It's kind of, I guess, what a lot of us think is a reason, because of that muscle insertions that will create this problem on the mandible. But I do think that they tend to go together. Usually you'll see at least a small tori on the maxilla and on the mandible at the same time, and then also maybe some exostoses too. But I will say there are a fair amount of times I've seen them where there's just the mandible, the lingual mandibular tori kind of isolated. And I, as far as anything else, I did look up to see if there's any incidents, but it's kind of all over the place based on where the study was done. I've seen as much as a 50% incidence. I think there was a foreign study. I can't even remember what country it was from. And then, maybe up to 20% of our population and the normal population. So I don't know if those numbers hold true, maybe we see them more. Obviously, we probably see them more frequently because it's something that we treat. And I will say, it sounds like there's one thing. If there's one thing that oral surgery is probably it's gonna remain within our realm, it's gonna be tora removal. I think that's the one thing
Probably.
no one else wants to mess with.
Yeah.
So, and including us, I think sometimes, right? These can be these can be very challenging. And again, if it's a lot of times they're patients that are older that need them out, and there's other medical stuff going on. And with our type of sedation that we do, unless you have an ability to use a CRNA, I think most of us are still doing open airway anesthesia as solo docs with nursing and things like that. It's management of the other complexities of the patient can be difficult.
Oh, for sure. And then I guess the next question kind of that leads off of that last question is, what are the indications for removal? Certainly we don't just remove every tori that exists, but at what point would you say, okay, this is a good thing to do to remove the tori for this patient?
I'll tell you, I would say that 50% I talk out of, maybe 20% probably need it, and I make them wait until they're almost that these are a super nuisance, and about maybe the other 15%, need them out when they come in for the consult. But of course, it's not super frequent. But I think that it's really got to interfere with your quality of life. There's got to be a real indication for the removal of these, and I would say that at least for the maxilla, it's patients that have the real shelf type tori, where they're kind of covering the palate, and then under there are these little undercuts where they can get a lot of food entrapment. That would be one. I also seen, I'm sure you have too, where we have this bisphosphonate related or this medication related exposure of that, because the tissue's so thin and the area just won't heal. Now, I don't typically that is not an indication in my opinion for removal, because you already have a defect there in the mucosa, and that's really not ideal. So usually what I do with those, if there's a piece of bone, I'll wait for it to exfoliate, or maybe just kind of burnish it down with a burr just to get a little bit of mucosal coverage. Same holds true in the mandible. I'm sure you're doing the same, or we do just gentle debridement of those medication related exposures.
Yeah. Yeah, similar for me. I'm surprised because I'll get dentists who see large tori and then they'll just say, okay, go see their oral surgeon and get them removed. And often these patients have large tori, and you ask them if they have any problems, and they say no. They're like chewing fine. There's no issues. Pretty remarkable. People can just have a regular diet and not have issues. But it's usually, when they, starting to get ulcers, they're big enough, they're touching, there's tongue and frenum impingement, there's other stuff going on, especially in the mandible, then that tips the scale. Usually, if they're symptomatic, to say, okay, well, let's remove them. But I don't remove them without like kind of a discussion, about how intense it is, because I think a lot of patients don't understand like that. They're older; it's going to be a longer recovery. This isn't just a couple days usually. What conversations do you have to kind of prepare patients for the post-op?
Yeah, it's interesting you say that about the patient coming in from the dentist, and I think that sometimes a patient will get to a point where they're just unable to take even bite wings or anything like that, and the dentist has become frustrated, or there's too much pain, and a lot of times these patients are not super cavity prone. It seems, I don't know, I just haven't seen a lot of them, but it does come down to patient finally makes the appointment to come in. They've been scared about it. They may read something about it. And it's usually, the dentist will encourage them because of that. And even I've had a few recently where the mandibular tori are elevated above the occlusal, almost at the level of the occlusal plane. And of course, that's impossible from a hygiene perspective. So, when I talk to patients about what this is going to look like, I kind of tailor it to, once I get to look at them, I get the scan and see how inferior the attachment of the tori is, because the more inferior, the more surgery we're going to need to. It's going to take longer time. There's more chances that you could get a flap dehiscence, or you're stretching the flap too much. So I tell patients that kind of like, I don't know, I talk to them about kind of like if I'm doing a tongue biopsy. A lot of times, some patients that'll have it and they'll just have very little pain, and then others will really have problems. And I think that the ones that stand out most for me that have had problems are ones that I had undiagnosed, or I couldn't, we can't really tell if people have some kind of parafunction. I don't know if you want to call it parafunctional activity of the tongue at night, or they're kind of these, there may be a sleep related component, of course, too, but their tongue is kind of getting after wherever we've worked, and that could be, maybe that's an association with bony spicules on the lingual after a wisdom tooth removal or something like that. But those are the ones where I found where if I'm unable to detect maybe some sleep disordered breathing or something else that would create this tongue mobility at night where they just are touching the area constantly. I'll tell patients like, well, I don't know, but those are the ones that are usually the most problematic and take the longest to heal and can be very uncomfortable. Grant, I think that the most important thing that I learned when I'm having this conversation with patients, which kind of has helped me have a better conversation, it's making sure I've got enough time for the procedure. So if I've got enough time and I'm really being careful with the dissection, usually, so I'm not pressed for time, meaning, and I take time with my dissection. I would say that a lot of times patients recover fairly predictably, and it isn't really too bad.
Okay. How about we can get into the technical stuff? What is your general technique for removing tori?
I would say that most of the time I'm removing the mandibular tori. At least that's in my practice. It's much more often I'm removing the mandibular. But maybe we can talk about the maxilla first, just because I know that it's something that does come in, and I'll usually start with a bilateral greater palatine block and the nasopalatine as well. Of course, all these patients we do discuss IV sedation. I'd say all of them have had it when we've done this, just because of three big palatal injections and lots of, it's a lot of manipulation. It's hard to get to, so having a patient, I think, in a good spot is important. And then I like to, for the maxilla, I like to use hydrodissection as well. So I'll go in with typically with the 1 to 100 Lido, and then go in with 1 to 50 with the 30 gauge needle, and I'll hydrodissect. So I'll just see the needle and just into the mucosa, and then just see the tissues kind of blanch out and then expand. So it's kind of done the dissection for me ahead of time. And I'll just wait a little bit, because I definitely want to have, especially on the maxilla, well, really both, but especially on the maxilla, just because of the, with the airway, things are going right down the palate, so I want to make sure that I've given it a good 5 minutes for hemostasis. And then I just like to go in straight on, like from the get-go, with a bilaterally based kind of Y-shaped releasing incision. And then I'll just go over the portion of the tori where I think I can most easily dissect. So I'll do that midline incision, and then the double Y incision based anteriorly and posteriorly, and then I'll begin the dissection. In the dissection, with the instruments that I use, it was the hydrodissection thing is what I saw my dad do one time, or when he was we were doing a case together, and he showed me a couple other things. One was the Goldman Fox. The Perio instrument has a couple of different angles to it, and the Goldman Fox there's a knife version of it, and I bought two, and I made one blunt. So I just kind of went into my lab and just kind of smoothed it off, so that they're like little paddles on the end, and they've got some strange curves to them. I know we're not doing a lot of perio instruments, but this is one that is on every one of any tori removal. I use these. One is the knife component, because it can help us, at least on the mandible and the lingual, elevate the papilla. From the maxilla, I like the blunt version of it. I think you can buy them too. It's like a tunneling instrument, but the Goldman Fox, because of its angulation, I'll just use a burr and just kind of really smooth it off so it's totally blunt. And then I'll just kind of do the dissection slowly like that after the incision's made. Most of the time, the tissue comes off pretty easily, but as we know, it can be tethered anteriorly and posteriorly, and because it's hard to access, especially distal or posteriorly near the soft palate, that's a lot of times where we'll struggle to get that dissected appropriately, especially if you're in the soft palate and you've got to make an incision through or within the um, the soft palate. And then really, I've done two different ways for the maxilla. I've done, like a modified burr technique. Where I take a round burr, lots of irrigation, and just kind of plasty. But I would say most of the time I'm using the shorter handpiece for the maxilla. I think it's a WHS. I think I looked it up. It's the S11. And I'll just go ahead and make some cuts, make a number of cuts as best as I can. And then I'll use a straight elevator and just try to elevate these components off. I've had at least two times where I was getting really close on after I had done this segmentalization of the maxillary tori, where I've gotten into the floor of the nose. So I know that there was one case that I had that one of the pieces took really there was kind of no bone left right there at the floor of the nose, and the rest of the pieces had come out without really much complication at all. I did not have a perforation into the nose, but there was no bone there. I found no sequela with that after, but I was bothered by it for sure. And then then once I get out as much as I can, then I'll just go back with a round burr, like a large round burr, and just kind of plasty off any of the sharp points. The hardest part I think for these is closure, though, right? I mean, the tissue's so thin. Yeah. You're always struggling. So I do like to close with the an RB or a tapered needle, and I'm usually using fluorochromic. I've largely, I don't know how you grab it. I don't. Everything I do now is all resorbable sutures. I don't even guided bone. It's all either Greco repeat or something else, and I'll just close it with a fluoro, with an RB, and just kind of taking my time to be real delicate. Making sure I'm not tearing that really thin flap. But when you see him back, it always looks pretty angry. Would you agree?
Oh, for sure. Yeah, that's one of those issues I feel like with that Y incision is one is just retracting that tissue out of the way so you're not catching it in the round burr. And then two, like you're saying, is closing it up. But there's oftentimes dehiscence, and sometimes it just has to kind of primarily granulate in there. Yeah.
Do you use any stent, palatal stent, or anything to afterwards?
Yeah, I mean, I try to always have those. I think it's helpful. I mean, from a pain standpoint too. What do you do?
I've tried it both ways, and I haven't really seen much differences in how things have played out. Of course, I think many of us are only looking at a limited number of samples anyway. It's not like we're doing these every day, you know what I mean? And maybe once a month if we're unlucky.
Right.
There's challenging. So, but I've done it both, and I think it's probably best to have a stent on hand in case you really do have a big flap management problem. So that's a good point.
Okay. Yeah, it definitely seems like we're doing quite a bit more mandibular compared to maxillary. Maybe just because the maxillary are more tolerable and they don't get to a point that are a nuisance, but for one reason or another, we do a lot more mandibular.
Yeah, that's a good point. It seems like maybe the dentists don't have problems on the upper as much, and patients. Yeah, I would guess, man. I think back on this. I mean, maybe for every lower that I see, whether or not I treat it or not, I mean, maybe every 10 lowers, maybe I'll have an upper that we need to talk about, but you're right. It seems to be much more adaptable. Patient can adapt better. And that's the thing with these is that it seems like because they're so slow growing that patients do tend to adapt really well, and can really navigate these, for a long period of time.
What is your technique for the mandibular ones?
The mandible is, I've done it a few different ways, but now what I try to do is, if I have to remove both sides, there are occasions where I'll just, or I've done just one because there's some asymmetric growth of one side greater than the other. So I'll take down the one that's the least problematic and see how that goes, and then leave the most the larger one. But typically it's bilateral. So I do like to start with lingual blocks, or I'll give infiltration near in the depth of the lingual vestibule, just in the submucosa there. I'll also use 1 to 50. After I give the block there, I'll also hydrodissect the tissues with a 30 gauge and 1 to 50 and let that sit for a while. I don't typically, I've done it both ways, where I've done a mental block or infraalveolar as well bilaterally. But we're done talking about suturing now, but I usually will just pass the needle through and approximately kind of loop and do a kind of loop around the teeth as I go. So it's kind of a running thing through the teeth. So I'm not really even engaging the buccal papilla there, just because it's quicker, and I just kind of go in and out all the way around, and then come back again and then tie it off. But I'll start with the incision at in the gingival margin of the most distal tooth in the arch, just behind it, and I'll use a 12 blade. I think the 12 Bs are also probably a good thing maybe to use, but I don't have any 12 Bs in my office. I only use 12s, just so we don't ever get mixed up in where the cutting surface is on the. So I'll just kind of use those cut on the inner surface. So I'll just start on the lingual aspect of the mandibular teeth, and I'll just swing it all the way around. I'll go from molar to molar, and then begin the dissection. After I do the hydrodissection, I'll begin the dissection with that Orban knife, and I'll just elevate all the papillas. And that's the hard part, I think, is when we have this kind of, maybe the taller mandibular tori that are sitting up, and you've got a really dense attachment from where the keratinized tissue meets the mucosa, and there may be even a little invagination there that becomes very difficult to elevate. And so those are ones where you just got to go slow, and then also when I get to that point, as we're moving anterior, I'll start with the Orban knife, elevate the papillas until I get to a more complicated area, and then I'll elevate the papillas, but then I'll use that other blunt version that I've created that will help me elevate without tearing anything. And so once I get the whole mandible exposed, the whole lingual, because I've found that when I've kind of skimped on the flap and maybe left something attached anteriorly, I've had tears and things like that. So I'll just release as much as I can, being super careful on those cases where they've got the tori, but they also have that maybe more of an exostosis lingual all the way back to maybe the third molar region. You know what I mean? There's like a little shelf. So
Yep.
Those are the ones that are really, to me, that's where the mucosa thins out so much distally on the lingual, because they've got those associated exostoses. Those are the ones that are really challenging for flap management, because they're just more prone to tear. Or so after I get everything reflected, I'll go and I'll begin just an osteotomy, just using, in this case, I'll use the longer handpiece, which is I think the one I use for third molars all the time is the S10. It's a WHS10. It's got the longer one. It takes those 65 millimeter burrs. It's a, electric handpiece, and plenty of irrigation, watching the airway, keeping everything as dry as possible while using, as much irrigation as I can. And then I'll separate it from the alveolus. And I'm kind of referring back, in these cases, I'm referring back to the CBCT just prior, just to see again what the angulation of the tori are, because I think that we can probably get away without having to go all the way down to the bottom of these in certain cases, and just kind of smooth off the back. You found that too?
Yeah. Are you using a round burr, you're saying, or a fissured burr? Or...
I'm using a 702, the long 702 burr. It's a 65 millimeter burr. It's a great white.
Yeah.
And so I'll basically just make a channel.
Mm-hmm.
And I'll just keep going with the channel. And because of this, the hand pieces are the real thin, long version, I can get in really close there. It isn't like I'm bumping up against the teeth. So I'll get as close to where the tori begins. Of course, leaving as much, you want to stay away from the roots and the alveolus as much as you can, and detach these, leaving some bone. Had a few cases where gotten very, very close as you're going inferiorly to roots and things like that. Lucky enough to avoid that complication, but a lot of times they'll be, you'll just because of the way they break off. There's lots, not much bone left there on the lingual. But again, these patients seem so resilient that most of the time the tissues thicken, they heal great, and bone kind of responds really well to insult. And then, so I'll just go down as far as I can, and then I'll kind of do a little wiggle. And my dad showed me this too. He would use a POTS, and we'd use a POTS, and we would try to elevate it off the alveolus. So whichever side you're on, you just kind of using the teeth and the alveolus as the kind of fulcrum, and just seeing if you get a little bit of movement anteriorly, posteriorly. I would say most of the time after I've done a section or gone back into it one more time, I can get it kind of loose, and then I'll just elevate anterior to posterior or vice versa. And then it'll just kind of start coming off because you're only attached maybe by 3-4 millimeters inferiorly. And then I'll just get in there with a rongeur and just keep wiggling. And then sometimes I'll get the rongeur with the POTS to give me a little bit more fulcrum. And then I'll just pop it off. And we know that all of us that take these off, that's really satisfying. When you get these.
Yeah.
Staff is on, and we feel great about ourselves because we've done a good thing for a patient, and there's no problems. And then you pat yourself on the back for that, for the left side, and then you go to the right, and you're like, shoot, I should have been so cocky, and you like, dang it, I got to do it again, But anyway, so yeah, then I'll take it off, and then I just get my Selden, and I'll take the Selden down to where that separation was to protect the floor of the mouth, and then I will guide the Selden will just guide around burr if I feel like I need to take off any sharp edges down there. Or you could use that's really the only time I ever use a bone rasp, I think, too. And then I'll just do tons of irrigation just to make sure everything's just really washed out, and because we know, that would be a bad place for an infection. But I haven't seen an infection after these, thank goodness. And then really I just let the tissue, I don't really do any. I know most of us, I would guess none of us do any tissue management. We just kind of let these kind of shrink up on their own as you have to.
Yeah, I use that almost identical technique. I'm glad you described that so well. But yeah, I also use a 702 burr, a trough, kind of right where the tori meets the alveolus. Trough halfway down. I use just like a large straight elevator, exactly like you're saying. Kind of pry it and see if there's any mobility. If there's not, okay, trough a little deeper until you're starting to get it move, and then elevate it off. I don't know, for some reason in residency, like there's all those different ways you try it, but we tried like large acrylic burrs, like pear shape and pineapple, and all these. I just left all that because all those big burrs are so likely to entangle in the soft tissue and just rip stuff up. So this seems to be the cleanest way, is to trough and just kind of elevate it out. It sounds like what you're doing is the same thing.
Yeah, I would agree with that. Is you think about, I remember that in residency too, just taking these giant burrs in the mouth, and they're pretty dangerous. They can catch things. Yeah. And I mean, the principle sounds, in principle, it sounds like it would be good because you could just smooth it off and it would just, but these are really dense and it takes time. And then there's more surgical time and more chances that patients can get a little, tickle down the throat, or a little bit of, moisture in the wrong spot. So, that definitely seems to be the quickest way, with the least amount of drama, I guess.
Yeah, and like you're saying, once you have elevated it off and removed it, I'll put my finger in there, feel for all the sharp spots, and then take a 8 round burr, smooth it, and then a bone file, and just making sure you got all those edges nice and smooth is a key part, I feel like.
Yeah, I would agree with that. I think just those little, it doesn't take long just to go in there, double check, rinse it out again, rinse it out one more time,
Yep.
and just make sure you're double checking. I had one that I had to reoperate on, that I missed a little bone. It was a little piece of bone, and it just would not heal. It was, with these patients, because their bone is so dense, did have to go back in and take off. There's only one time that I've had that happen, so far, luckily, where there was just a little bit of bony protuberance that it was trying to exfoliate but wouldn't, and then I had to go back in and smooth it off. So I'm super cautious now. So I'm glad you mentioned that.
And then any, I guess, major, not major, minor or major complications? I mean, I don't see too many other than just sometimes it takes a little longer to heal and maybe some pain. But just the other day, I had a colleague saying that he saw a patient who had tori removal, and then they, from a different surgeon, and they had developed a plunging ranula. I mean, kind of rare stuff, but have you seen anything like that?
I really haven't. I guess that would make sense though. If you do entangle some of those lingual tissues, you could have some trauma. But I really haven't. I would say the only thing, which I alluded to earlier, was when I've had a couple of patients that were real flap manipulators, and not on purpose, but maybe even daytime, where they would manipulate it, and then I had flap necrosis, and they're memorable for sure. Where I've had that happen. One was bilateral and one was unilateral. So there's only been two that I recall, but I remember them because we were really dancing around these for a while, and making sure I was seeing the patient a lot and following up with them a lot to get these granulated in. I do like to use. I would say that the suturing, maybe I think appropriate suturing and tissue management at the end is important too to minimize complications. I mean, it isn't. I mean, this is not really difficult things, but I do like to use on the mandible. I'll use occasionally. I'll use a cutting needle, but I think that I'll just kind of going in and making sure that you're getting good, um, good bites of the mucosa. I mean, of the keratinized tissue, and you're really getting good adaptation. So you're caring for the flap. And again, I'll go through the teeth, and I'll just kind of, as opposed to tying it off at each one, I'll go through. Typically, I'm just using a non-cutting needle, like an SH, like a 4.0 from a cutter SH, and I'll kind of pass it through the lingual tissue and then reverse the needle out. So I just kind of pass it through passively and then wrap around the buccal and then kind of come through and then go back again and then tie off once in the back. I don't know. I mean, I think that making sure that the closure's good is important, but I don't know. I don't know if that really, again, it seems like these patients just typically are very resilient healers. Would you find that?
Yeah, for sure. Yeah, I feel like there's those mandibular ones, there's a lot of extra kind of sagging tissue, and I don't know, maybe because of that, there's potential for more swelling to kind of build up in there, or fluid, but I do the same thing you do. I pass the suture around the teeth and kind of cinch it out down between each tooth there. But it's rare. I see too horrible of edema or swelling or issues. They're pretty resilient people.
I will tell patients most of the time they'll think that these are not gone at first because they, like you said, they will fill up. These tissues will, there'll be a fair amount of edema there. But then over a number of weeks this will shrink up. So I think that there's, when I do get patients back, I typically do a follow-up. I think I do a follow-up, say 2 weeks, and then I'll do a 6-week. That's usually what I do. And then most of the time, 2 weeks, there's still some bogginess and maybe a little bit of, that the edema there, firm edema, where the tori were. And then by the time they come back at 6 weeks, it's pretty much gone.
Nice. Just to follow up on a couple of those instruments that are kind of new to me, but you mentioned the Goldman Fox. Do you know the number on that? Which periodontal instrument that is?
Yeah, I was looking at that. It was actually, I meant to say I mean, you can use a Goldman, and let's see, but I think the Orban is probably better. I really don't even know the difference between them. But when I was looking them up, Goldman Fox came up, but I noted on Salvin's got an Orban knife. That's probably what I would get instead of the Goldman Fox. But I think I don't know. I don't really know the difference between them. I don't know if you do, but
I
yeah,
don't.
I would.
Cool. I'm looking at it online. I haven't used those, but it looks like it would be a good tool to elevate those tissues, especially on the mandibular. We're trying to get in between sometimes the teeth there, and it's kind of an awkward junction, lingual to the teeth.
The other thing I did see was this tunneling knife. that was also on the Salvin website. And the tunnelers can be good. They have a tunneling kit I saw that I had never seen before. It doesn't really have a lot of angles to it, but there's a tunnel knife number 2, and that might be one where that's already blunt tip with the angulation. That would be that kind of as I was describing.
Nice. Well, that's cool. Good to. I'm always up for trying new instruments and seeing if there's more efficient ways to handle the soft tissues and just make the whole procedure go smoother. That's cool.
Yeah, I think most of the time when I think back on the cases that I do, I feel like there's the patient comes in to interview me, and then they'll go for a year or two, and then they'll come back and they're like, okay, well, I think I'm ready now. I've had a few though, and really that are just like they are ready to go. I had one patient that they were just like, I'm ready. I've had it with these, and they really literally scheduled the next day. I had a spot. Like, no, I'm not waiting. And then usually I'm just like, hey, pump the brakes on this, give it some thought. We don't want to rush into this. But this one patient was just these were really difficult ones, and there was food when I reflected it. There was actually food in these are mandibular. There were food trapped under. It was one of those crazy cases, but they were so done with them. Like, all right, and usually I try to have them really think about this for a while, because I think that maybe it's like anything that we do. The more volume that we have, maybe we can be, a little bit more, like with wisdom teeth, when patients come in, it's things we see very, very often. And I think that with Tori, there's always little nuances that can make it difficult on a patient. So I really like them to be real, have thought about this and be ready for it,
Now, another question is in regards to lateral exostoses. I mean, pretty rare, but sometimes we see those big buccal, basically like tori, just on the buccal instead of the lingual. I mean, do you ever remove those, and what's the indication?
Yeah, that's a good one. I think that let's see, there was a case I remember that there was a large buccal exostoses near first molar. I decided to it was a difficult removal, as you might imagine, the first molar removal. And I was like, I think I need to remove this exostosis but I was like, maybe it'll be okay because, but I guess there was some flap trauma and man, the thing just to hiss completely. And just because of, I don't know, I mean, I was careful with the tissues and I did mineral reflection, uh, but it just the whole thing to hiss. So, but that's kind of nowadays. I'll just always if I'm dealing in a localized spot, I'll take off as much as I can of that to give me to not have as much pressure on that really thin flap for edema and for problems for necrosis, because that really was that was a problem. But I would say in general, the ones that I've taken off are the maxillary, where they have a little ledge, and I will just go in and take the whole segment off, and most of the time I'm just using a large rongeur to kind of clip them off. It seems like they come off real easily, and just to kind of detach. You know what I mean? And those are, I would say, those are also less frequent. I had one patient that I recall, this is probably 10 years back, where all 4 quadrants were large shelves. In fact, you could see them on the outside of his face, like it was looked like there was, I mean, it was obvious deformity actually. And so I had to do buckle from all the entire maxilla and the mandible. Again, it's kind of extreme, but most of the time I'll just, whatever one is bothering them, that's the one I'll take off. But most of the time, again, it's the maxillary that are the ones that I remember most, and they seem to be the bone on the maxilla. Obviously, is a little bit easier to deal with, and I think they separate much easier, and they always heal great. So I haven't had a problem up there. I did have a couple on the mandible that I've removed that are also shelf-like, and I've had a lot more often than not though. When a patient comes in with large ones, they're not bothering them. They work around it. And that's fine.
Yeah, it seems like the rare times they remove those is maybe there's some issue with a denture that needs to seed, or it's rare that you have any aesthetic complaints. Like maybe once or twice I've seen where there's large enough that a younger patient may want those removed. But yeah, like you're saying, they pretty much tolerate those, and they're not kind of in the way because they're not on the lingual where you're chewing, your tongue's moving, and all that type of stuff.
It does bring up the denture aspect to this, and I think that a lot of dentists can work around, even not super big maxillary ones, but sometimes you can work around those. On the mandible, I'll kind of do an anterior base flap, and take them off more with the crestal incision, if I have to.
Yeah.
It seems like that's pretty rare, though. Most of the time, patients with tori keep their teeth because, again, they're something with their biology is more resilient, maybe, and they're less, maybe they're, I don't know. It's occasionally, though, of course, we have to take those off for the mandibular denture. And I think flap management in those is a little bit easier, but still not a picnic.
Yeah, for sure. Well, that's been good. I really appreciate you running through that. Any other comments about tori removal?
I don't think so. I kind of go back to the patient making sure that they're coming in and they really are ready and they really thought about it. Because even though most of their cases go really smooth, occasionally patients can really have some problems, with pain. And I really want them to be ready, and I want to have established enough rapport with the patient to get through those complications. I think that's the main thing. Spending enough time. I think the two things that would probably be the most important to me is getting to know the patient before you tackle something big like this. And then the other thing is having enough time for the surgery. I think I was trying to think about how much time the staff is really good about to schedule me the amount of time that I typically take for these. But I think really for a mandibular tori, I'm usually allowing myself 45 minutes for bilateral mandibular tori. And I don't want to be pressured in. If there's any chance that these are going to be extra difficult, I'll have them at, it'd be a full hour, just so I don't. That's one thing I don't want on these is any time crunch, because that stress, and then you're pushing things, and that's just not good. So that would kind of be the two things that I would say are most important.
I totally agree. Yeah, I've become a lot more conservative and cautious with removing these and making sure there's a big indication. Because sometimes I'll have these on my schedule for like consult and surgery at the same day, and just because a dentist told them to do it and they're not having problems, and I'm gotta pump the brakes and be like, this is potential for it to be multiple weeks of pretty sore and long recovery. Like you're saying, I think it's kind of our responsibility to kind of take their hand and say, hey, here's what this is. This isn't a quick extraction and you're better in 2 days type of a thing.
Yeah. Just on that note, do you do a fair amount of consult surgeries?
Yeah, we do.
Okay.
Just in the model that we're in. But yeah, I've trained most of my referring docs with tori, to kind of say, let's do a consult first, and here are the indications. And it's so funny because it's very similar to what you're saying. Usually we see them, we describe it, and then like they're gone for a year, and then they come back and say they're ready now. It's funny how that works.
I hear it another time, and then they need to hear from the dentist again that you're okay, that I referred you to the right person, you're in good hands, okay, and then they think about it some more, and then go online, and then so yeah, and that's my dad used to do a lot of consult surgeries. It seems like I really now I don't really, I kind of gravitated away from that in my model. It's always a consult first, and then surgery later. But occasionally we'll do a consult surgery, but of course not for this particular thing. That's an aside. But it is good if your dentist sets you up really well for that. Patient's time.
One more thing I just wanted to bring up was kind of the coding / billing. It seems like removal of torus mandibularis, I think, is D7473. Is that code you're using? D7472 for the palate?
I reached out to my staff about just seeing if coverage is, it's kind of, I guess, depending on how you what the plan and the medical coverage and things like that. Occasionally they said medical will cover some of these or a portion of these. A lot of times they do, a lot of times they don't. And then, since we're in PPOs, we usually will get a predetermination as well. So we'll see what their coverage is going to be, and then just collect what insurance isn't going to pay for those. But it seems like most of the time, and quite often, patients are out of pocket. Some on these.
Yeah. Seems like some of the insurance, like for one, mandibular torus mandibularis, sometimes is only 200 to 400, maybe. I mean, for the work that it takes to remove these and the technique and how sometimes the long follow up, it seems a little out of proportion for the cost, to the OR time and the patient follow up time. I mean, but it is what it is. But I do think that's why sometimes these patients kind of get, kind of like a hot potato pushed around from provider to provider, because there'll be docs who just don't do it because of that.
Yeah, that's true. That's a good point, and that is a difficult conversation to have with patients too. About reimbursement levels for something that's what is one of the more difficult things we do, I think.
For sure. Well, good stuff to be aware of, at least if you're doing these. The other thing I was going to say, is once we reflect our flap, we'll use like a Selden. What do you use to retract that lingual tissue on a mandibular?
Selden.
Selden, yeah.
Mhm. Yeah.
I mean, you could use a periosteal, it's just thinner, and kind of really want to make sure you protect that lingual tissue. It's a mess if a round burr or something catches that lingual tissue.
You're so right. Yeah, that's where I'm really paranoid, and we're really making sure. And I'll even get a, since I've got a pretty wide flap reflected, I'll get a Minnesota in there too if I can, like one of those off angle Minnesotas that give you a little more visibility. I'll get that in there too, making sure that the end of it's not sharp, because sometimes our Minnesotas will get sharp.
Yeah.
And some things too. Once you're down there and you're hitting it a lot, you can get a really sharp edge on those.
Yeah, that would probably be the type of thing that could potentially penetrate some of those tissues and cause a ranula or something weird. So definitely want to make sure you got nice, smooth, rounded retractors down there.
Yeah,
but
for sure.
Awesome. Well, if you're good for it, I could put your contact in the show notes in case listeners have further questions about this. That could contact me as well.
Yeah, I put it. I've got a little PowerPoint I made, or keynote, that's got all the things I wanted to make sure we talked about, and just some. I mean, it's just some basic things I think you need to do well with these, and then I've got pictures of I can give you a PDF of the hand pieces we were talking about and the burr, whatever, if you want it.
Yeah, that'd be fantastic. Well, we end every podcast with some rapid fire questions. So, first one is, what is the best book you've read in the past year?
I listened to Hearts of Atlantis, and it was William Hurt and Stephen King actually read it, and it was so well produced. There's music in it, and it's such a fun book to listen to. And I would say another one that's a really good listener is Bono's autobiography is very, very good too, because it's produced really well, and there's music throughout, and it's great. I usually like to, but as far as books go, I usually like to do something that's a nonfiction and then a fiction at the same time. And we did a really good one with a small book club that we have, which is it was, what's the name of this book? It's hang on, let me look this up real quick. Yeah, it was Hidden Potential by Adam Grant.
Okay.
And it was good. He's a good writer, but I think what it did more mainly was when we got together as a group, it really gave us a lot of things to talk about. And then really a hugely impactful book for me that I reread this past year. I think it's from Richard Powers. It's called The Overstory. It's a number of stories, and it's about trees. And there's a number of it's fiction, but each one of these stories, there's some connections there. But it is a magnificent book. So I reread that, and it's powerful. It really is. And you wouldn't think. I mean, how can you book about trees with like 10 stories about trees be intriguing? But it is. It won some awards too. So that was another good one.
That's awesome. I'm always looking for good books, so I really appreciate those Those Rex. How about what non-oral surgery thing do you do in your life that translates to the operating room and helps you with your daily skills?
I think it's the main thing. I think is photography for me. I've been
Okay.
taking photos forever, and I love. I do take a lot of intraoral photos. I like to do provisionals, immediate provisionals in my practice, and immediate molar healing abutments and things like that. So I do like to take photos, but I also take them. So it's kind of like I've been able to bring my hobby of working with light and cameras into the operatory, and it's really helped me learn too because I've got just such a large, um, you know, library of images, clinical as well as at least 100,000 hobby photographs as well. So I think that'd probably be my one outlet that really has helped me grow as a surgeon is using my photography clinically to see how things are playing out. So I remember.
Yes, I love that. How about what forceps do you use to extract tooth number 5?
Number five, I think. Hmm, I don't really know the name of it, but it's a one of those titanium. Maybe it's an A Titan forcep. It's black and it's got a little give to it, and it can grab really far down the root. And I don't even know the name of it, but it's a I'll put it in. It's always my go-to, and I'll put it in that PDF. But it's just basic premolar forcep, but it has the tips kind of can grip a little further down the root rather than kind of grabbing. It goes a little bit further apically. I can engage it further apically.
Is it
So
more
what
like
about you? Don't
is that more like a upper universal shape or more like an ash?
It's more like an upper universal shape.
Okay. Yeah, I mean, I use either like the 150 or the ash. KLS Martin has a great ash that I use that they're just grab on the tooth and you can really twist as opposed to, of course, you want to be really careful
Mm,
if you're using an ash going buccal lingual because you'll snap off a crown. Yeah,
I'll have to try that. I got to check out that ash. The ashes that I have I don't think they're really that good. They're mainly I think they're pediatric versions. So I'm going to check into that.
yeah, for sure. How about best movie or TV series you've seen in the past year?
My wife and I have been watching, we did Breaking Bad, and now we're doing Better Call Saul. And just the storytelling and the cinematography, everything about them is just like we have to force ourselves to only watch 1 hour every single time we do it. So we do it pretty much every night. So we're working through Better Call Saul now.
Nice.
And, I do like to watch things with the family too. And I would say that we really like watching. My youngest is 16. So we still get a little bit of time with him. And
Yeah.
we'll watch Bob's Burgers. That's our go-to every night with the family TV. And it's just a fun show. It's well written. It's appropriate. Most of the time, fairly appropriate. Because I was looking at we did another one just to say, hey, let's check this other one out, and it's the same thing. It's TV 14, and I mean, I know he's 16 and he's way beyond all this stuff that as
Yeah.
parents that we're worried about. You know what I mean? But still, but we did another one, and it was man, it was out there. So yeah, we're gonna stick with Bob's Burgers for now. We're working through all those seasons. We also did too that was fun as a family was we did Modern Family. We did that when my daughter was growing up. We'd watch that, and then we watched it again as my son was getting a little bit older, and that's a fun one too. So,
Yes, it is.
what about you? You got anything good that I need to look into?
Well, my kids are a little younger. Mine span from 18 to 7. So I don't know if you've heard of Young Sheldon, but we watched
Yeah,
that whole series.
that's a great one.
We just get a kick out of it. I love that, like the whole Southern aspect and the contrast between like a super intelligent nerd and the Southern culture and how they kind of teach each other things about life is just hilarious.
It really is good. I haven't we watched that. I think we watched up until maybe about 2 years ago. I don't know why we stopped watching it, but I guess they're still coming out with new. Is it still they're still making new episodes?
I think they just did the final like season 8, I want to say it is.
Okay.
But they're
Yeah.
all really well done, good messages. I mean, um, pretty
Mhm.
good stuff.
Yeah, I'll have to look. We might have to get back into that one.
My daughter is like 14. I've been watching The Summer I Turned Pretty with her because she wanted me to watch it with her. And those things you just got to do as a dad to spend time with your kids.
Yep.
But
Whatever you can do to get that little bit of time together. I mean, and it's just time. It doesn't even have to be. No, I'm with you. You got to figure out if they're interested in it, I'm
yeah,
doing it. You know what I mean? Was that a movie or is that a series?
it's a series. Of course, it's like, oh gosh, it's kind of cringy. It's one of these. It's like a love triangle where this teenage girl's got these two brothers that are in love with her, and kind of like Twilight. I mean, I shouldn't go off on this, but I feel like women love this, where there's at least two or three men fighting over them, and they can't choose which one, and they're all so glamorous and beautiful and like smart, and you're like, oh my goodness, this is ridiculous. This would never happen in real life.
That's funny. Yeah, that's pretty interesting. Maybe we need to read more and watch more of those movies so we understand women better. Maybe
Yeah.
that's the way. It's just so foreign to us to read books. Anything to do with that. That's funny. Yeah, that's funny.
Yeah. How about last question is
Mhm.
favorite quote? Do you have a favorite quote or a mantra that you kind of come back to in your life?
I have these pop up reminders on that come up on my computer, and one I would say the it's not really a quote, but it's breathing. So the thing will just pop up on my computer, and it would be just take 4 breaths, 4 deep breaths, and that's been the biggest thing for me. I think over the past 5 years is just taking some moments, you know, breathe, and that's it. And I'll just do a little reminder on my Mac, and it'll just pop up, and then it'll say, "Take 4 deep breaths." And it's just there, and it's not every day at the same time. It's different times, and it's just to get me in the habit. And now that I'm in the habit of it, I'll remember, like in the car, I'll take some deep breaths, and just to kind of, I don't know, it just for me it de-escalates, everything.
Yeah.
So I would say that that's probably um, the main thing, and um, yeah,
Love it.
that's probably the biggest thing.
Yeah, I love that you mentioned that. Um, on our way to school, I usually drive my kids to school, and we pull up the Calm app. I don't know if you're familiar with the Calm app,
Mhm.
but Jay Shetty has this thing called the Daily J, and he does like a 7-minute meditation on some
Mm,
aspect of life, and it starts with 3 deep breaths and ends with the breaths, and so I'm always trying to listen to that and have my kids calm down and breathe, and
that's
I think,
great. That's
yeah,
great in the morning to get them in that habit. I'll make one thing that that I did do with my kids is when I because I always brought them to school too, is we would there was a book called it's the small things, and they're all small things. I can't remember. It's like a Richard Carlson. Is that the name of it? And it's basically little stories, little feel good stories, and I would have them read them to me on the way to school. So I got them involved in something that was. And so we would always read these, and the book, man, it got so much use. It was falling apart. No, don't sweat the small stuff. It's all small stuff. And it's just little stories. It's a small little book. And it got us all doing basically the same thing as just slowing down a little bit. I like that yours better because it's even more, a little more intentional with breathing and relaxing. I'm glad you also mentioned that too, because I decided about 2 weeks ago that I'm turning off. I'm not reading the news anymore. I feel like maybe it's not good at this point, but I'm going to try, and I'll just listen to classical music in the car now. And because you got that, everybody's got the free, NPR station that's usually got classical in there. And I've turned off all news completely. And it's not that it's any, I really don't think it's any worse now than it's ever been. I mean, the nerdy news is always there in our face and always ready to push our buttons or not or distract us. But
yeah,
man, I'm so much more relaxed on the way. I just, even though I like to stay up, I want to stay current, and we need to be aware of what's happening in the world. But I've decided that I'm going to be so much more deliberate with just that little bit of mental energy that goes into listening to I mean, I don't know, whatever you listen to on the radio. And now we've got so many options with satellite. I got rid of my satellite radio because I was always listening to doctor radio, always trying to, you know,
Yeah.
get something, some edge and improve and all this. I'm like, wait, I'm just going to take this 10 minutes in the car and just going to listen to some classical music and just chill and take some breaths. And that could be, because that could be a real meditative time, depending on what your commute is, that can really be time that's spent um, very mindful. And then when you get to work, then everything's, it's different. You got a lot of, you got a lot of hats and everything. So and that's been very, very recent. And I haven't picked it because I like the Wall Street Journal app. I listen to some NPR. I like to get my news from as many sources as I can, just to, I don't know, but not anymore. I'm just going to take some time off, and I know that I'm sure people do this all the time and attempt it, but it's just, I've been very relaxed for the past 2 weeks. I'm getting really good headspace. I feel like I have less ability to talk intelligently if I get together with some friends and we're talking about current events, super current events. But most of that stuff doesn't matter anyway, because it's just, these are all short-term problems we're having. So,
Yeah.
but anyway, I just thought I'd mention that because that's been good. I think it's good. I think that little time with your kids in the car in the morning, make the most of that. I miss this time. I really
totally agree.
I remember the last time I brought my son to school when he got his car. I mean, I really had a moment. I'd been bringing my kids to school for, gosh, sure. It's just the thing that I really enjoyed, and remember the last day when he got his car, and that was it. Man, it was tough on me, to really miss those times, those special times we had together. So I'm glad to hear that you're doing that. Really fun memories.
Yeah, I love that. Try to seize the moment. I feel like the older I get, the more time just feels like it's going so fast, almost like I'm holding sand and it's slipping through my fingers. My oldest is about to leave the house here, so you just like, wow, it just seems like yesterday she was just a little 2-year-old and you're holding her, and next thing you know, she's walking out the door.
Yeah.
But critical.
Capturing, it is critical. You're right, capturing those times together. My son and I made our trip when my kids turned 16. We take a trip together. That was something that I'd always wanted to do. And my daughter's now in dental school, and we had a really great trip when she was 16. And then my son and I went on a trip, and we'd been planning this trip for so long. I mean, because he had made a decision about where he wanted to go when he was like 10 or something like that, 9 or 10. And then all of a sudden it was here, and we went, and it was this past summer. And, so it was, there's closing those little chapters makes, it does seem that the passage of time becomes much more tangible. And then, but I do think that all those things are the magic of being a parent, is going through that, and going through those times really lead to give you an emotional depth that is hard to have with if you don't have kids. It's also can be very painful too, I think. But
Yep.
So anyway.
Well, good. I'm sure all this relates to removing Tori. It's got to have some parallel.
I don't know. I think it all blends together, man.
Separating the child from the family group and slowly pry them away, and they have to go off to college.
I love that. That's a perfect tie-in here. You're right. It is perfect. Yeah, pry them away. Yeah.
Well, I appreciate you sharing your thoughts on various topics. I'd love to do another episode with you. You're an awesome person, and
thanks, man.
Very nice of you to share all that.
Yeah, this was great. Thanks so much for asking me and helping me put this together in my mind, and then talk about it. It's good to talk about these things, even the not so exotic stuff that we do.
That's right. Yeah.
So keep up the good work, man. I really think what you're doing is great, and you're feeding a lot of people's connecting a lot of people deeper. I think it's great to be able to talk about our profession, and as dedicated as you have been to this, because this is a labor of love. I know that, as we had talked about too. So be encouraged by that, and that they're affecting a lot of people in a good way.
Yeah, I appreciate that, and good luck to you in your efforts and in podcasting and working and all the things you got going on.
Thanks so much, man. Yeah.
All right. Have a good rest of the day, Rick. Appreciate you.
Okay. You too, man. Take care.
Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.